So when we talk about treatment of eating disorders, there are two overarching goals. The first goal is to correct whatever abnormal eating pattern there was. Afterwards, we're going to deal with the underlying reasons for the eating disorder, so the broader psychological or situational factors. Now, I said to you earlier in the previous video that it oftentimes requires family and friends. So, families' buy-in is very important because, again, they serve as models, they serve as critics. They're the ones purchasing the food oftentimes, so they clearly play a role. All right, so let's talk about how we're going to deal with anorexia. The first thing you're going to deal with is increasing weight. Everything stems from that, because if you have a person who is significantly underweight, it is going to cause a tremendous amount of health problems. So we want to restore weight to make sure that we reduce the risk of serious health problems or even death for that matter. But after we deal with that, we have to deal with malnourishment, right? Because if you're restricting your diet to a certain amount of calories, or you're only eating a select number of foods, oftentimes you're not eating the proper amount of vitamins and minerals. So we have to deal with malnourishment. And then eventually we use dietitianists and nutritionists to teach proper eating. So if we were to think about it, it used to be that if a person had an eating disorder or anorexia, they were hospitalized. And that was the go-to because they're in a controlled environment, which is going to reduce the risk of them continuing whatever pathological eating there is. Now, more often than not today, the treatment of eating disorders happen outpatient, right? So there is a movement not to have to hospitalize a person or to send them to some kind of rehab. That's not how we do it typically today. Does that mean that there aren't times where that is warranted? Of course, there are times where it's warranted. You can get a court order to hospitalize a person if their weight is significantly low to the point where you think they're a danger to themselves. So there is that piece. You can also get a court order for forced tube feeding, right? The problem with forced hospitalization and forced tube feeding is it really destroys the relationship with you and your client. If it's necessary, do it. But if it's not necessary, be careful not to jump to that right away. Now, how we do it today is we typically use an integrated team that includes a psychologist, sometimes a psychiatrist, a nursing team, dietitian, nutritionists, working all together to try and address the needs. So the medical team is going to deal with the physical challenges that were created, but we're also going to work on increasing the calories in one's diet. And I mentioned to you that I'm working with someone now who has anorexia, and this is one of the biggest discussions we have, is the importance of eating more than they typically do. And my position when they said, "Oh, but I'm not hungry," I said, in this particular case, because you're so underweight, you might have to eat a little bit between meals, even when you're not hungry, to increase the calories so that you can gain weight. We estimate that it's about 3,500 calories per pound. So if we know how much a person is typically eating, we can create a higher calorie diet to target, just an incremental increase. And the client that I'm working with now, they started with eating one meal and one snack. So clearly, the amount of food they were eating was well below the expected calories, right? Typically, if you're non-exercising female, the lowest number of calories you're supposed to eat is about 12 to 1500 calories. For a male who's non-exercising, it should be anywhere between 15 to 1800 calories. So we can figure out what the difference is and incrementally work you up. And it takes time because we know we're not going to get you there overnight. It could take anywhere between 2 to 3 months to get you to a point where we're good. Now, in the case that I'm dealing with today, I work with the pediatrician. I work with the parents, and I work with the client, all to get on the same page to make sure that the client is gaining weight. And the good news is that we got them to about 100 pounds now. Now, they were maybe around 96, 97 pounds at the beginning, but we're working our way up. All right, so there is a question. Do you slowly add more calories for them to eat, or do you raise it at one time? No, it's gradual. If you try and jump too fast, you're not going to get the buy-in of the person. It's going to be too psychologically distressing. So you might work them up. So, and how we did it was we went from a meal and a snack to 2 meals and a snack, to 2 meals and 2 snacks, and then 3 meals and 2 snacks. So it is a gradual process. So that's a real good question. All right. Now, in terms of the underlying problems, you have to deal with that afterwards, right? So first you deal with the restoration of weight. Another tactic that I used for the malnourishment was they have things like Boost and Ensure, which are meal replacements, but they're like vitamin and mineral dense meal replacements. So knowing that they started out only eating one meal, one snack, another tactic we used was to use the Boost, which was a drink, in replacement of that second meal, just to deal with some of the malnutrition and the vitamin and mineral being off. So it's tricky. It is very hard to work with a person with anorexia because you have to convince them of something that they don't believe. I think I talked to you in a previous lecture about using simulated bodies to show what their weight was and what their weight would look like if they gained 5 pounds, if they gained 10 pounds, because their distorted body image was so strong that otherwise they were just not going to do it, right? So it's delicate. But we also, if we want to make sure that the person sustains their recovery, we can't just increase their weight and send them on their way. We can't just deal with the malnutrition and send them on their way. The core of the psychological distortions or psychological problems, that must be addressed. And if it's not addressed, then there is no lasting recovery. So one of the goals of therapy is to increase insight, but also to educate the person on what the problem is, what exacerbates their symptoms, how to address when a person feels stressed, and so forth. So there is a psychoeducation piece here too. Now, when we talk about a focus of therapy, one of the goals of therapy is to build autonomy and self-awareness. You may recall I said a driving force of the development of eating disorders is the feeling that we don't have control over our life. So if I can't control anything else in my life, I'm going to control how much I eat, what I restrict my diet, and all of these things. So building a sense of autonomy or independence is important. So that's the first thing. You want to help the person feel like they're part of the team and they have autonomy. We also want the person to develop some sense of self-awareness. So starting to pay attention to those internal feelings that are kind of the alarm bells that go off that trigger starvation diets or binging or whatnot. So that's very, very important to help a patient understand, what's happening internally. So from that's the insight, that's the educational piece. From a cognitive point of view, we have to deal with those cognitive distortions. So when I ask the person, do you feel overweight now? Or are you dissatisfied with your body now? And they said yes. That's when you have to say, well, okay, what about if your friend had the following body type? Would you feel that their body was unattractive or whatever, or they were overweight? And then they say no. You force the client to reconcile the inconsistency. So you say, well, how is it that you have one standard for yourself and another standard for other people, right? So you have this dialogue to bring the contradictions to the forefront. Now, I said to you, changing family interactions is important. So family therapy is important. So if you have a family member, particularly a parent who's overly critical or overly controlling or comments excessively about the physical appearance of their child, you work with the family to understand why that is not helpful. You also try and teach the family boundaries and not to become overly enmeshed. Allow that person their own sense of self without being trampled on. So changing family interactions is absolutely important. Now, typically, I said we use a combined approach. If you go back, I mentioned that you might have a psychologist, a psychiatrist, a nurse, a dietitian, and we put it all together. We talked about just now family being involved. Even with all of this put together, recovery is difficult. And it's important to understand that people are going to relapse. Not everyone is going to fully recover. And it's individual from person to person how much they recover. So you have to be, delicate, and you treat a person as unique. Now, when we look at weight gain, with treatment, weight gain usually happens pretty quickly. I said to you that it oftentimes happens within 2 to 3 months. We can get you back to a healthy weight. Now, I said to you, one of the symptoms of anorexia is that a person can lose their menstrual cycle. So when you restore your weight, usually the menstrual cycle returns as well, anywhere between 2 to 3 months later. Now, we talked about death by suicide as well as death by health complications related to anorexia. The rates are declining. I mentioned 2 to 6%. It used to be upward of 10%. So there is, with treatment, things are getting slightly better. Now, here's the negative. Not everyone is going to fully recover. We see that about 20% of people who are in treatment for anorexia relapse, or oftentimes are struggle for many years to follow. So even if we can get some early recovery or a period of time of recovery, it's not always permanent. Similar to a substance abuse problem, you could have a person who struggled with an eating disorder, and it could be 10, 12 years later, and the right stressor could set them all the way back. So if you have this significant stressor in one life, let's say 10, 12 years later, they're in the midst of a divorce, that person could revert back to eating disorder tendencies. And even those who recover still have lingering or latent body dissatisfaction. So they still express concerns. So the treatment is not perfect, the same way the treatment for substance abuse is not perfect. Not everyone is going to recover, and recovery is not a linear process. Relapse is going to happen. So that's anorexia. So let's talk about the treatment of bulimia, right? So treatment programs for bulimia have increased, fairly new. We didn't usually distinguish between anorexia and bulimia in terms of the location of treatment early on, but now we have very specialized eating disorder clinics that target just bulimia. So there's been a shift. So if we were to think about the goals, think about what we said about anorexia. The first goal for anorexia was to restore weight because that was the most pressing. The first goal with bulimia is to address the binge purge patterns, right? Because this person is starting at a normal weight or perhaps slightly overweight. So with bulimia, we're going to target the binge purge pattern. We're going to break the connection between binging and purging. And then afterwards, we're going to restore healthy eating habits. And ultimately, in the end, we're going to deal with the underlying causes. Notice the deeper psychological and social factors, which are absolutely essential. They're the last we target, because in order to get lasting change, we deal with the most pressing first, but we still have to address it at its core, at its root. And again, similar to anorexia, psychoeducation is a very important part of treatment. So if we were to use insight-oriented therapy, so individual insight-oriented therapy allows a person to identify or recognize distorted thinking about food, distorted eating patterns, distorted body shape, and so forth. Using insight-oriented therapy, we get about 65% of people stopping the binge purge cycle, right? So it's not great, if I'm going to be honest with you. That means that about 1/3 of people are not going to stop with this alone. So we do use cognitive therapy in conjunction with interpersonal therapy to increase the gains. So cognitive therapy is used to focus on the distortions, and interpersonal therapy, which is interesting. Now we're focusing on relationships, right? It's not just insight. The interpersonal piece is more important with bulimia, because when we talked about bulimia, we said one of the differences is that bulimia, it's more socially driven. It's more seeking the approval of others. So there is going to be an interpersonal piece. And then we also have support groups such as Eaters Anonymous. There are different kind of support groups, phone groups, etc. Now, interesting, right? So we target individual therapy, insight-oriented. We target cognition. We target relationships or interpersonal therapy. And we put you in groups. And a combined approach works much better. So let's talk about a behavioral paradigm. I said one of the goals is to break the connection between the binges and the purges. So one of the behavioral strategies that is used is what's called exposure and ritual prevention. So exposure is when we present something that's going to induce the desire to binge, right? And we don't allow it. Or if a person binges, we block them from purging. So by blocking the connection between binging and purging, or interrupting that, we reduce the association. And by reducing the association, it actually helps reduce the symptoms of bulimia. We also use antidepressants. One of the pieces of research we talked about was that serotonin was linked to both mood disorders and eating disorders. So would it shock you that serotonin, or SSRIs, are used in the treatment of bulimia? Now, the drugs in isolation only treat about 25 to 40% of patients. So obviously, we're not going to use individual insight therapy alone or pharmacotherapy alone. It's best if we combine medications with a whole host of therapies. Now, group therapy. What is the difference between a support group and group therapy? It's basically, as I said, I believe in lecture 1, group therapy requires a licensed and trained professional. So the benefit of group therapy for eating disorders is that it creates a community. And there are a bunch of people going through the same thing, and you can learn from the experiences of other people. Now, group therapy coupled with individual insight therapy results in improvement in about 75% of the cases. So now you're seeing multiple modalities being incorporated to increase the effectiveness of treatment. Now, let's pull back. If we were to think of individual insight therapy alone, 65%. Medication alone, 25 to 40%. Combination of factors, 75%, right? So we do see that there is still a group of people that are going to struggle. Now, you do need treatment to get better with bulimia. It is, if left untreated, it does not just go away typically. So let's look at the data. We see that with treatment, there's an immediate, or at least a short-term improvement of about 40% of the cases. And a moderate improvement in another 40%. So we have about 80% accounted for. And of those people who have recovered, we see with treatment about 90% have in a 10 years or later, 90% of them remain either fully or partially recovered. So treatment is tremendously effective relative to being left untreated. We're not saying treatment's going to work for everybody. We're not saying that everyone's going to get better, but we can see the data is pushing towards treatment. Okay, so who is going to have a greater risk for relapse? Well, we know that stress is a universal trigger to all mental illness. So anyone who is under a significant amount of stress is going to have a greater risk for relapse. We also know the longer you had a history of those symptoms without treatment, the more likely you're going to relapse because you've developed the more entrenched pattern. People who used vomiting as their purging type are more likely to relapse than people who use other modalities. People who had history with substance abuse and people who have interpersonal problems or relationship problems, all of these groups of people are going to be at greater risk for relapse. And that, my friends, is our lecture. So I'm going to stop the recording here, and then I'm going to do what I did the last time, which is a pullback for some reflection.